need the first presentation.
Okay, so you need your presentation, your slides here. Yeah, I think we have them.
It's a long way from.
We'll just wait a few minutes until everybody else comes down, and they all have that same walk, I'm sure.
Tanimak was sitting in the first row.
Yes, so he has to wait for everyone to come out, yes. Yeah, coming from all the way down at the, yeah, did you come from there too? Yeah, yeah.
No, they were.
Confirmatory session.
Becky, all the slides are up. Is this a slide? Yes.
Nee, van Nodal Confirmatory session. Die juist van het toernet is vrij identiek hetzelfde als de prescription. Dus wij herhalen de tweezame herhalingspakken. Dus mijn vraag was, en ik ben al geweest aan de prescription, zodat ik van de middag de sessies kan opnemen. En de prescription zijn het ook online krijgen. Well, it's confusing. It's the last session, the science session, like me always come up with them.
I have the session model chair in the 11. Yeah.
You have to leave on that?
Yeah.
So we're trying to get, make sure Tony knows that too. That's good too. Thank you for letting us know that. It's been that kind of week.
WCLC, they tell us that the descriptors must be the same, clinical and pathological. Quantification of nodal disease. So far, only works at pathological. Difficult to count lymph nodes. Even if you use CT or PET scan, you turn the images. Sometimes you count 2 or 3, sometimes 5. You never know. So we cannot change, but I think quantification is still useful to intensify. Yes, sure. I know that many people would like to have the N categories subdivided, as in other tumors. So far, I think we are a little bit conservative. And another thing is that the present categories work very well. They separate the tumors nicely. Prognostic groups based. Yes. Very challenging. This is a big challenge. Yes.
Ich werde noch schauen, da gibt es einen Poster für die
Is there something going on in the clinic? No.
whom I have taught, delighted.
Good morning. Thank you for coming. We are running a little bit late, but we were just heard that the plenary session where some of our speakers are coming from just broke up, so they're on their way. Unfortunately, it is a long walk down the hall, so give them a minute and they should be here soon. We're going to start with Dr. Wu. He does have to leave at 11 o'clock, so we will take questions on his research and his presentation right after he talks, okay? Thanks.
Tommy, go on, Tommy, go on. Oh, I said, that is sound.
So I was telling that this it's a sort of new collaboration in China and other countries because for someone in training, for example, it's better. To do 40 resections. 8 patients sometimes. So it's really impressive what you are doing. Yes.
Okay, we're going to get started, and the other speakers will join in progress. As I said before, Dr. Wu has to leave at 11 with an urgent meeting. So we're going to kick off the press conference with his presentation first. His slides are up, and he'll be happy to answer any questions after his presentation. And as the speakers come in, we'll have them introduced for you, okay? So Dr. Wu, why don't you begin?
Okay. Yeah, good morning, ladies and gentlemen. So here I will release our phase 3 clinical trials comparing the whole brain radiotherapy and the chemotherapy with the EGFR-TKI accordingly in non-small cell lung cancer with the brain metastasis and the EGFR mutant patient. This is my discourse. So far, in the standard of care, the treatment with the brain metastasis is the whole brain radiotherapy. This is recommended by the NCCN guideline. But with the radiotherapy, the PFS, this means the patient live no progression only the 4 to 6 months, and the disease control rate 52%. Before we have so many retrospective analysis about the EGFR-TKI, the gefitinib, this is the first generation EGFR-TKI, the response rate 33%, and the disease control rate 70%. And 3 years ago, we published the phase 2 clinical trials. This is CTON-0803. They showed the response rate 58.3%, and the disease control rate 75%, and the median PS 15.2%. But so far, we have no any clinical trial head-to-head comparison with the WBI and the EGFR-TKI. So the Icotini is the first generation TKI in China. In the 2013, we are comparing the Icotini with the gefitinib. That time they showed the same efficacy and the same toxicity. So based on this data, we are designing the phase 3 clinical trials. We are involving the patient, the EGFR mutant patient, and multiple brain metastasis. That means that at least 3 lesions in the brain, and then the patient will randomize to Icotini versus the WBI. And then if the intracranial did not under control, so the Icotini will plus the WBI, and the Icotini continue the treatment. If the WBI did not under control the brain metastasis, so we are switched the WBI to the Icotini. And if the extracranial progression, So we have also the treatment icotinic or the switched the drug into the icotinic, and then the for the oversurvival. And this tries with the comparing the intracranial progression-free survival and so generally the progression-free survival and the oversurvival and so on. And this is the result. This is the patient characteristics. We are comparing the gender, age, equal performance, and scomacities. And most of the cases are the adenocarcinoma, and most of the patients were the EGR common mutation, including the exon 19 deletion and exon 21 the mutation. And also we are including the brain metastasis with the symptom. That means they have patient had a headache and another symptom, the patient into the clinical trial. And this based on at least both arms, all the factors are the balance. So this is the primary endpoint, the intracranial PFS. So please find here, this is very, very good result. In the icotinic arm, the median survival, the 10 months, but in the WBI, the 4.6 months, this had the significant in the statistic. And the heart ratio, the 0.46, that means the icotinic decreased the disease progression in the brain, the 44% the patient. So in the 6 months, in the icotinic, 72% versus the WBI, 48%, and the 1 year, the 47% versus the 43%. So this is the second endpoint. The PS means the including the cranial progression or the extracranial progression. So EASLC, the icotinic near the 7 months versus the WBI, 3.4 months. Also, the heart ratio, 0.44. And then this means the decreased the metastasis, the 56% patient. And also in the 6 months, 55% versus the 22%, and the 12 months, 90% versus the 90%. So this is the oversurvival. The overall know the difference between two arms. And the intracranial response rate and the over response rate, in the intracranial, the over response rate, the 67% versus the 40%. In the intracranial disease control rate, 84% versus 70%, and they both had a significant difference. So in the oversurvival, that means the increase the intracranial and extracranial, the response rate 55% versus 11%, and over disease control 78.8% versus the 54.8%. Also the significant difference. The treatment-related toxicity in the icotinic, the totally only the 8.2% of patients experience the grade 3 or the grade 4 the toxicity, but in the WBI plus chemotherapy, 24.9% the patient grade 3 the toxicity, and 15.7% the grade 4 the toxicity. So what is this result? So this is the result. I show you the take-home the message. First, the blend data prepares the first phase 3 result comparing the EGFR-TKI with the WBI. The second, the icotinic improved intracranial PFS and the PFS in the EGFR mutant non-small cell lung cancer patient with the blend metastasis. And with the favorably the response rate and the disease control rate, icotinic was superior to the WBI plus or not the chemotherapy. And finally, icotinic should be used in the first-line treatment for the advanced EGFR mutant non-small cell lung cancer with the blend metastasis. Yeah, thank you very much.
Thank you, Professor Wu. My apology for being late to moderate this session, as I was late in the other session. So, question from the audience. actually from the press, media friends.
Question is Linda from Escape. The discussant mentioned that we don't yet know whether this is going to have the same effects in non-East Asian populations. I just wondered if you wanted to comment on that.
Non-Asian.
A non-Asian patient. So I think that the EGFR TKI, so far, if the patient with the EGFR mutant patient, the EGFR TKI showed a similar result with non-Asian patient or Asian patient, and so such as IPAS, the IPAS, and the UTEC, the clinical trial, all showed a similar result. I think this is not the problem, the same as,
The only point I would like to add on is that the pharmacokinetic of icosapent in non-Asian has never been studied. Icosapent mostly developed in China, and so therefore the current dosage of pharmacokinetic has actually not been investigated. Okay, if there is no further question, thank you, Professor.
Because I want to chair another.
I know. You go ahead. You go ahead. Now, our next speaker, which is supposed to be the first speaker, is Dr. Rami Carter, and he's going to talk about the staging system, which is actually a very important system that we do apply clinically to our patients every day. And then IASLC has taken great pride of creating this system over the past 8 versions. This is the 8th version, right?
Yes, it is. Thank you very much, Tony. Thank you for being here. This is by necessity a very short presentation, and I would like to inform you that the IASLC has published 2 books, one handbook, which is given for free in one of the booths in the exhibition area. It contains the basic chapters of the bigger book, the TNM classifications of lung cancer, mesothelioma, thymic tumors, and esophageal cancer. And then at the IASLC booth, you have the manual with more chapters giving more background information on the new editions of the TNM classifications. The presentation that has taken place earlier this morning is a sort of follow-up to the one we had in Denver. It was also a plenary session where we described in more detail what was at that time a proposal of the IASLC for changes to the 7th edition of the TNM classification. Now all those changes that the IASLC proposed have been accepted by the UICC, the Union for International Cancer Control, and the American Joint Committee on Cancer. The AJCC manual is already published, and it has all the innovations that the IASLC proposed. Here, I will just concentrate on the points that might change our clinical practice. And the first one is that, as we found in the 7th edition, tumor size counts more than we thought in the previous editions. Actually, from less than 1 centimeter to 5 centimeters, every centimeter defines a new category based on tumor size. That's for the T primary tumor. But we also have incorporated new players to the playing ground. We already defined in 2011 the adenocarcinoma in situ, but there was no category in the TNM. Now we have defined TIS, parenthesis AIS, adenocarcinoma in situ, for adenocarcinoma in situ, and we need to write AIS to make it different from squamous cell carcinoma in situ. We have also coded a minimal invasive adenocarcinoma, T1MI, which is a tumor less than 3 centimeters in maximum size that contains a solid part that has invasive tumor, but up to 5 millimeters. That's the minimal invasive adenocarcinoma for which we have now a category. And we have redefined the smallest solid tumor, T1A, which is a tumor, solid tumor, invasive tumor of up to 1 centimeter in greatest dimension. So, precise measurement of tumor size. We have to be very careful because a few millimeters change prognosis. So it's very important. How are we going to measure tumor size? The letter of the TNM classification does not tell us. It just says that we have to register the greatest dimension. But the IASLC now recommends to do it on the CT scan in any projection that gives the largest dimension and using the lung window, because if we use the mediastinal window, we may underestimate a tumor size. Continuing with the T component, pleura, invasion of the visceral pleura has proved, again, to be an important prognostic factor. We define in the 7th edition 2 types of visceral pleura involvement, invasion transgressing the elastic layer, which is a thin layer within the width of the visceral pleura that can only be seen by the pathologist under the microscope, and then the invasion that reaches the lung surface. The first is PL1 and the second PL2. Both types of visceral pleura invasion separate tumors with different prognosis, but this is just a pathological finding. We cannot assess a clinical staging, so we don't use it to subclassify visceral pleura invasion as a descriptor, but it's important to refine postoperative prognosis of those patients whose tumors have visceral pleura invasion. As you probably know, if you have been around, there will be no changes in the N component because we don't really need them. The present categories N0, N1, N2, and N3 separate clearly different tumors, both at clinical and pathological classification. However, we played a little bit with the idea of quantifying nodal disease, as we did for the 7th edition. Then in 2007, we did it counting the number of involved nodal zones, a new concept that we developed back in the 7th edition for those patients who would not undergo resection and lymphadenectomy, just to make the N classification easier. For this time, we have done it counting the number of stations, and the number of stations is important. N1 single station has better prognosis than N1 multiple stations. N2 single station without concomitant N1 has better survival than N2 single station plus N1 and N2 multiple stations. So, but all these quantification analysis are very well done at pathological staging in those patients who underwent resection and had a properly performed lymphadenectomy. When we want to translate this into clinical staging by counting the number of involved nodes, involved zones or stations by CT, PET scan, or a standard mediastinoscopy, it doesn't work. All the survival curves are very erratic. It's logical. The means that we have to classify, to stage tumors clinically are not so perfect as when we do it with a complete lymphadenectomy. So quantifying nodal disease is important, and I think the message here is that we should try to quantify both at clinical and pathological staging, because at least it has prognostic implications. We can refine the prognosis for a given patient. We can have a more strict follow-up, or we can intensify adjuvant therapy for these patients, and we will be able to stratify future clinical trials on adjuvant therapy for pathological nodal disease. For the M component, little changes but relevant. M1A, intrathoracic metastasis, remains unchanged. N1B is now divided into the new M1B, single extrathoracic metastasis, and the newly created M1C category to define extrathoracic metastasis, multiple extrathoracic metastasis, either in one organ or in several organs. The importance here is the single extrathoracic metastasis has the same prognosis as intrathoracic metastasis, and it may be the starting point to try to have a consensus definition of oligometastatic disease, which is now relatively loose, including from 1 to 5 metastases. Sometimes some people consider it only in one organ, others allow several organs. So I think this is the base ground from where we can start redefining
concerning oligometastatic disease and oligoprogression. So there are some changes in the stages. We have subdivided some stages. We have created others. We have divided stage 4 into stage 4A for M1A and the new M1B, and stage 4B for M1C. And finally, the IASLC has published 4 very important papers on how to classify lung cancers with multiple lesions. We see them more often now than 20 years ago. And if you read the letter of the classification, it's very ambiguous. It's prone to multiple interpretations. So what we have tried with the components of an ad hoc committee and trying to analyze the data, where data is, we recommended 4 rules for 4 different patterns of disease. First, multiple primaries. We have 1 TNM for each category. Separate tumor nodules, there is no change if it is the separate nodule in the same lobe, it's T3. Different lobe, same site, T4. Contralateral lung, M1A. For the newly defined adenocarcinomas, part solid adenocarcinomas with a GGO component, ground glass opacity and CT, or lipidic growth under the microscope, then we use a very old rule in the TNM. We use the highest T, and we add between parentheses the number of lesions that we can identify, and an N and an M valid for all the tumors. And for this relatively rare type of adenocarcinoma, the pneumonic type adenocarcinoma, we go back to the T3, T4, M1A rule, depending on the lower location of the adenocarcinoma. So, to do this, we need something. We need discipline. And I know that invoking nowadays the word discipline, which is disappearing from the dictionaries, is very outdated, but I was born in the last century, so by definition, I am old-fashioned. But, you know, precise measurement, it needs discipline, not rounding off loosely, trying to measure, you know, centimeters and millimeters, because some millimeters count. The use of the elastic stains, only 50% of pathologists use it routinely. So the quantification of nodal disease, it requires at least attention to read the CT scans correctly, to see, to compare with the PET scan, to do a proper mediastinoscopy, not just biopsy, but resecting all the lymph nodes that we can identify at mediastinoscopy. And then for the last few seconds, to follow the rules. It's very difficult. We are human beings. It's difficult to follow the rules. But now we have clearly defined rules. We may agree with them or not, but if we have the discipline to follow them, we can see if they work in the future. We can change them if they don't work. Thank you very much for your attention.
We're open to some questions. Just a slight additional note is the fact that for clinicians, this is a system that's so important that the important question the patient asks you, how am I doing? What is my prognosis? This is the system that we're relying on.
I'm not familiar with the term elastic stains. Could you define that?
Elastic stains, yes. The normal stains that the pathologist used is hematoxylin, eosin, which are components that stain the different components of the cell. But there are special stains to highlight and to better visualize the fibrotic tissue. So the elastic layer has a different component. So these elastic stains highlighted under the microscope, and you see within the width of the visceral pleura a black line. So if the tumor transgresses this line, then it is invasion of the visceral pleura. That would be PL1 if it does not reach the lung surface. If the tumor reaches the lung surface, then it would be PL2, 2 different types of visceral pleura invasion. You're welcome.
Any other question related to the staging system? If not, thank you so much. Thank you. Very welcome. And the next is actually going to be presented by my good friend Vali. And then this is a project that we share, so I have declared a little bit conflict of interest. It is a randomized phase 3 study comparing osimertinib with pemetrexed and platinum in patients with the T790M mutation.
Thanks, Tony. And indeed, most probably Tony can give this press conference even better than me. But these are very exciting news for our patients, actually. In the T790M group, just to put it in context, for this group here, most probably you are very familiar, but this is EGFR mutated non-small cell lung cancer. About 40% of the Asian population presents this way, and about 15% of the Western population. These patients are treated with EGFR tyrosine kinase inhibitors, and usually with variable duration of response, they will develop resistance. The major mechanism of resistance is T790M, and osimertinib is a mutation-specific, irreversible inhibitor, EGFR TKI, specifically designed to address mutations sensitizing and the T790M. So we already came today with the knowledge that this drug is exquisitely active in 2 global phase 2 studies, the extension AURA and AURA2. We knew that the response rate for patients with T790M ranged from 60 to 70%, and the progression-free survival was 9 to 12 months approximately, and that had led to accelerated approval of the drug under the breakthrough designation program at the FDA. So this study that I presented today, the AURA3, is the confirmatory trial. It is the first trial of its kind to actually compare standard of care chemotherapy with a third-generation EGFR TKI. We had previously done that in frontline therapy with gefitinib versus the standard of care. Dr. Mock was the first author of that study. So what did the study show? There was overwhelming benefit from osimertinib. The progression-free survival was superior for patients treated with osimertinib, 10.1 months median progression-free survival, and then 4.4 months for the chemotherapy arm. The hazard ratio was 0.3, meaning a 70% reduction in risk of disease progression or death without disease progression for these patients. Not only that, but that was an investigator-assessed progression-free survival. The central assessment of this progression-free survival totally agreed. Actually, the hazard ratio was 0.28, with a median progression-free survival for osimertinib of 11 months and 4.2 months with chemotherapy. The benefit was spread among all the subgroups that were predefined, and it was an impressive benefit. The hazard ratio was less than 0.5 in all subsets of patients that were looked at, including Asian versus non-Asian ethnicity. Depending on the concurrent mutation with the T790M, the hazard ratio was better for patients with exon 19 deletion, very consistent with what we know. And there was overwhelming benefit for patients with CNS metastasis. The hazard ratio for these patients was 0.32, and for patients without CNS metastasis, it was 0.4. So the conclusion from this study, the first randomized study of a third-generation EGFR TKI for patients with T790M resistance mutation against standard of care platinum pemetrexed chemotherapy, is that osimertinib had statistically superior and clinically meaningful efficacy compared to chemotherapy. There should be no question based on a PFS hazard ratio of 0.3 and a progression-free survival of 10.1 months, 5.7 months more than chemotherapy, what we should be giving to our patients in this setting. Overall response rate was 71% for osimertinib, 71%, and 31% for chemotherapy. So as already said, the benefit is substantial. In the setting of CNS metastasis, it is also very impressive. And we can now officially call this the standard of care for these patients. But what is most important, and I think the audience needs to know, and the oncologists need to remember, is that to actually deliver this treatment, you need to do the test. You need to find the T790M to offer the best therapy to your patients. So that should be impetus for us to test the tumor or the plasma. And those are all my comments.
Thank you.
And Professor Mark, please answer this as well if you have a different opinion than your colleague. So my understanding is that if you do a liquid biopsy to identify a T790M, it's unreliable. You have to do a direct biopsy. And could you briefly explain, is anything known about why that's the case? And it's not clear to me, do you then need to do, if you don't identify a T790M initially, do you have to do serial biopsies? And if so, what would be the time frame for doing those?
Yes. So actually, there is a presentation that will address the plasma biopsy for this particular trial. This was one of the endpoints for this study. So I don't want to steal Dr. Wu's thunder. He's actually presenting it later. But this study also demonstrated the benefit based on the plasma testing.
Right. Maybe I have to clarify the question is
Yes.
the fact that the concept of false positive and false negative. So in a way is that once the plasma is positive T790M, the chance of it being false positive is very low. This has been demonstrated. So therefore, patients that are plasma positive can proceed to treatment directly. But on the other hand, the plasma test, because we're just only catching the DNA in the blood, we still have a substantial chance of being false negative. So when a plasma test is negative, in order to eliminate the chance of it being false negative, we have to proceed with the biopsy. So I think that would be...
And are serial biopsies needed if the first one?
No, serial biopsies.
So usually, the patient cannot wait for your serial because they already got evident progression. They want their next line of treatment. So once you get a biopsy that's negative, then we can proceed with the standard chemotherapy. We should not be waiting for the serial until something else happens.
But after you initiate standard chemo, would you ever biopsy subsequently?
Yes, the answer is yes. Because there is always the possibility of missing a rare population or a subclone. The tests, the plasma tests, are getting more and more sensitive. So that's the other component of this that I think we will come to increasingly rely upon them to make the diagnosis. But at this point in time, the default is the tissue.
And is there any time frame for subsequent biopsies if you do get negative ones initially?
I think it will have to depend on the clinical scenario.
That's right.
So at this moment, there's no standard on how frequent you should do it, but it's just really on the judgment of the doctor.
But the assumption is that these patients are going to receive standard of care chemotherapy, and therefore, upon disease progression with chemotherapy or intolerance to chemotherapy, that would be the right time to rebiopsy the patient.
Okay. Any other? One more. Okay.
I actually have another if nobody else has one. So is there any possibility to even think in terms of using osimertinib as a first-line TKI? And it's not clear to me how generally, if the answer is no, but what makes a TKI first-line and second-line in this setting?
Okay, so the answer is yes. There is a lot of thinking because there is actually a large randomized study that is comparing osimertinib in the first-line setting with the standard of care EGFR TKI. So the results of this study are eagerly awaited by the community. And of course, we're all very encouraged based on the data that we saw today and the data that we had seen before that actually this drug may beat the standard of care, but we need to wait. So for the patients at this point in time, the standard of care remains an EGFR TKI, and the new standard of care for T790M mutation positive patients is osimertinib. For the remaining patients, chemotherapy is still the standard of care in the second line, if you want to think about it this way, unless you discover another mechanism that you could potentially offer the patient a clinical trial that targets that molecular alteration. But standard of care is as I explained. So I hope this answers your question. Maybe, Tony, you have some comments?
I think to summarize what you said is the sequence of the TKIs can only be addressed in the light of the Pleura study, the randomized phase 3 study. So before that, I think it's all speculative.
And when are the results of
next year sometime.
Next year.
Next year sometime. Okay, any other question from the media? If not, thank you much, Melanie.
Thank you.
Thank you. All right, let's go to the next one. Another exciting study going to be discussed by Dr. Gilberto Di Castro from Brazil, and he's going to talk about first-line ceritinib versus the extended chemotherapy in L-positive lung cancer, phase 3 study 6 and 4.
Thank you, Professor Mock. The study we have just presented was the first-line ceritinib versus chemotherapy in patients with all-career-ranged non-small cell lung cancer. Something is happening here.
Yep.
It was a randomized phase 3 study. These are my disclosures. It's a very short presentation. I think it's more important than ever, and probably you will agree than me, that we need to consider lung cancer, and especially the cancer we have studied, the non-squamous non-small cell lung cancer, is a very heterogeneous disease. So we need to every patient, as most as possible, to submit the sample to the lab and ask to the pathologist, please do check some genetic alterations that can driven the carcinogenesis in these patients. And some of these markers can be considered as predictive markers. We have just discussed EGFR as a predictive marker, and in this population we are going to discuss the ALK-positive tumors. In fact, in the Western world, generally speaking, ALK-positive tumors are found, in fact, in around 4 to 5% of patients. But if you study the non-smoker patients, this fraction can reach 15% of all patients. So it's a very important, it's not so rare disease. Up to now, the first-line treatment for these patients was either chemotherapy or, if you have access to the drug, crizotinib. In this paper, we studied the efficacy and safety of ceritinib, a second-generation ALK inhibitor. Crizotinib is considered a first-generation ALK inhibitor, and here we discussed a second-generation ALK inhibitor. It was compared head-to-head, ceritinib versus chemotherapy. Chemotherapy is a contemporary treatment, including a platinum pemetrexed doublet, followed by pemetrexed maintenance, considered as a standard of care for this non-squamous, non-small cell lung cancer patients. And in fact, ceritinib demonstrated a statistically significant and clinically meaningful improvement in progression-free survival when it was compared to chemotherapy. The progression-free survival, the most important result of this abstract, favored ceritinib. The progression-free survival was 16.6 months versus 8.1 months, with a decrease of the hazard ratio from 45%. The hazard ratio we found was 0.55 with a p-value less than 0.001. This improvement in progression-free survival was robust and, very importantly, consistent across many subgroups of patients, including those with and without brain metastasis. I would like to stress, for example, that in those patients without brain metastasis, we could find a progression-free survival of 26 months. It's a very impressive result. And in those patients with brain metastasis, and please take into account that 3 of 4 of these patients with brain metastasis had active brain metastasis, the progression-free survival reached 10.7 months. We also found a higher response rate, 72.5% for ceritinib versus 26.7% for chemotherapy, and also a longer duration of response, 24 months versus 11 months, favoring ceritinib. The intracranial response rate was higher for ceritinib, 72.7% versus 27.3%. And it's important to stress about the incidence of adverse events. The adverse events on ceritinib are frequent, but in general, they are considered as manageable and acceptable. For example, those patients who had treatment discontinuation due to adverse events were only 5% in the ceritinib arm. And the main conclusion, ceritinib should now be considered as a new option in those patients diagnosed with or rearranged advanced non-small cell lung cancer.
Thank you, Gilberto. Any question from the audience? I think it's quite clear cut. One of the options. Okay. So under the note, then in that case, thank you very much.
Thank you.
So I guess this will basically conclude this press meeting. And again, I thank you for your time attending to this important information, and we really rely on you to spread the good message around. Thank you so much. Thank you.
Thank you, Tony.
Gilberto. How are you?
Thank you. I'm fine, and you?
Congratulations.
This is very good data.
Okay, thank you.
I saw it, with market team, and the only part is on the Asian bit. We have to explain later on.
Yes.
Later on, that's why not to talk about it this time because it's
How much
sufficient
time do
data
you
here.
have?
Yeah. Okay.
It's okay. Thank you. Thank you.
No problem. Yeah.
When would be possible for you to do it?
Yes, that's
Well, why don't you tell me what